Welcome to EmergencyMedicineCases.com. I'm your host, Dr. Anton Hellman, bringing you Canada's brightest minds in emergency medicine from EMC Studios in Toronto. Our two experts on this episode on acute heart failure are Dr. Brian Steinhart and Dr. Eric Letovsky. Dr. Steinhart is an emergency physician at St. Michael's Hospital. He is certified in emergency medicine by the Royal College of Physicians and Surgeons of Canada and the American Board of Emergency Medicine. He has conducted and published original research in cardiac biomarkers and has been a delegate for Heart and Stroke Foundation Canada and for the American Heart Association. Dr. Eric Letovsky is the Chief of the Emergency Department at the Credit Valley Hospital in Mississauga, Ontario. He is Director of the Division of Emergency Medicine in the Department of Family Medicine at the University of Toronto, where he is a full professor in the Faculty of Medicine. It was only about 3 weeks ago today that we launched the website, and in order to make this the best educational experience for you that we can, we need your feedback. Please give us your feedback. There are two ways you can give us your feedback. One is by emailing me directly at Anton, that's ANTON, at emergencymedicinecases.com. And the other way is to go to the individual episodes on the website and type in your comments in the comments section. Acute heart failure remains an often difficult clinical diagnosis for emergency physicians to make despite its high prevalence. Its clinical presentation overlaps with many other causes of acute shortness of breath. Many of the historical, physical examination, and X-ray findings have poor accuracy. In addition, there are multiple confusing and complicated classification systems for heart failure that are not applicable to EM practice in a practical or useful way. To top it off, in contrast to chronic CHF, there's very little good hard evidence for any of the medications we use for acute heart failure. In this episode, we will attempt to demystify acute heart failure, to provide a useful classification system that helps guide ED management, and to suggest the best management for these difficult patients. When we don't have any good hard evidence for managing ED patients, we look to the experts with experience. Dr. Steinhart and Dr. Letovsky have a combined clinical experience of about 60 years, so I'm sure you're just as psyched as I am to hear their take on acute heart failure. The episode will be divided into two sections. In the first section, we'll present a case where the diagnosis is not so obvious and discuss the usefulness of historical features, physical examination findings, lab tests, and imaging. In particular, we'll discuss the utility of BNP and whether or not we should be using it in Canadian emergency departments. In the second section, we will present a useful classification system for acute heart failure and discuss three cases that reflect this system. We'll review the best practice for different medications and ventilatory support. Finally, we'll end with a discussion on how to best determine disposition. So let's jump right into the first case. We have a 60-year-old man with a known history of COPD who presents to your emergency department with increasing dyspnea, orthopnea, and cough over the past 3 days. He reports coughing up some yellow sputum with no hemoptysis. He denies chest pain, ankle swelling, PND, calf pain, or fever. He takes puffers for his COPD, which he took many times that day, but he forgot the names of them. He denies any other significant medical history and has no known risk factors for MI or thromboembolic disease. He quit smoking many years ago. On exam, he appears alert, but has peripheral cyanosis and is in moderate respiratory distress. His blood pressure is 140/90, heart rate is 120, respiratory rate is 32, O2 saturation is 90% on a non-rebreather, and his temperature is 36.5. His chest examination reveals a barreled chest with diffuse expiratory wheezes and no crackles. His JVP is 3 centimeters above the sternal angle. His heart sounds are distant. He has no palpable hepatomegaly. His calves are equal in size and non-tender with scant pedal edema. An ECG reveals sinus tachycardia with evidence of right heart strain. The chest X-ray shows hyperinflated lungs with flattened diaphragms, dark lung fields, and some increased hilar markings. Before we get into the nitty-gritty of the case and of acute heart failure, let's look at the bigger picture and ask, For patients who present to the emergency department with acute shortness of breath, what in general are we looking for? What's our differential diagnosis in general? Dr. Letovsky?
So my big picture approach to patients who are short of breath is when I pick up a chart with someone who's short of breath, I ask myself, is the patient having a cardiac problem causing the shortness of breath, pericardial effusion, congestive heart failure, for example? Number two, is the patient having a primary respiratory problem, such as a pneumonia, pneumothorax? Number three, is the patient having a hematological problem? Is the patient anemic? We need hemoglobin to carry oxygen to the tissues. Is the patient severely anemic, causing the shortness of breath or high output heart failure? And fourthly, could the patient be having some kind of neuromuscular problem? We need inadequate bellows to adequately oxygenate and ventilate, and patients with neuromuscular diseases can present with a sense of shortness of breath as well. So those are my four big major categories of dyspnea: cardiac, respiratory, hematological, and neuromuscular when I see a patient with the shortness of breath.
And Dr. Steinhart, do you have anything to add to that?
Well, it's my approach as well, but I would add, as in any presentation, somatoform disorders are there as an etiology in the background to be considered when the common and the serious etiologies have been ruled out and there's nothing tangible to grasp. It can present itself in many weird and wonderful ways, including shortness of breath.
So knowing that there's a considerable overlap between COPD and acute heart failure presentations, what features in the history and physical do you particularly look for to help you distinguish between these two entities and decide whether they have one or the other or both?
If you have past history available, either from relatives, from the patient, or from your health records, and this presentation mimics a previous presentation with the same complaint and a confirmed diagnosis of either COPD or heart failure or something else, then that raises your suspicion for the same etiology, everything else being equal.
I don't think it's any single item in the history, physical or ancillary testing, which favors COPD versus congestive heart failure. It's really features from all categories, which helps you put together a picture of heart failure. There's historical features of increasing weight gain, edema, or perhaps lack of appropriate use of medications or increased salt intake, which are important historical features. There's some very important physical features, third heart sounds, RALs, peripheral edema, which suggest heart failure. There are important chest x-ray findings, which suggest acute pulmonary edema, and there are important ECG findings. So it's really putting the whole picture together using history, physical, and testing. But it's important to remember that sometimes it's very difficult in the initial stages anyways, in the initial few minutes, to try to distinguish between COPD and congestive heart failure. And in fact, it's not uncommon to start treating both diseases at the same time. It's not uncommon for us to give oxygen, start Ventolin and Atrovent, and give a shot of Lasix furosemide at the same time while we're sorting out the difference between the two.
Does the literature help us out in terms of how good each specific history or physical examination feature is?
So I'm a proud Canadian, and Sir William Osler was Canadian, and he was knighted and is one of our heroes for his bedside diagnosis acumen. This was at the turn of the century, and he was a role model for thousands of physicians since then and has been literally placed on a pedestal throughout the world for his bedside acumen. Unfortunately for Sir William Osler, robust research has evolved and technology, and much of what Sir William Osler touted as being dogma and irrefutable for bedside diagnosis cannot be supported today, and acute heart failure is one of those diseases, and the short of breath patient is one of those complaints. So with that in mind, when we look at meta-analyses of this very point, what is relevant on history and physical examination to rule in heart failure and rule out the other cause, there is not much we can hang our hat on. When Eric and I were interns, it was really easy to diagnose the short of breath patient. They had a history of requiring 2 or 3 pillows at night, to sleep, and they might even wake up and sit upright because they're short of breath, and they get better. And they come in with a few crackles, and we would say, this is heart failure, Lasix, admit to the hospital, and it was easy. But we were wrong. We didn't know we were wrong. Nobody knew we were wrong. But the literature has told us it's not that easy anymore. In fact, it's getting worse. You alluded to a combined experience here of over 60 years in emergency medicine. I, for one, find it more and more difficult to diagnose these short of breath patients because they're getting older. They're surviving their cardiac and pulmonary insults, whereas when we started out, they died, right? They had a heart attack. You put them up on a ward or a CCU, you gave them morphine, you watched them die. Now, things thankfully are a little bit better. At times, it is so difficult. Even the best clinician, the most astute clinician with history, physical, and chest x-ray can be extremely difficult, as Eric says. It's not getting easier. So that said, there's not much to hang your hat on. A past history of heart failure is ranked with a likelihood ratio of 5. And as we know, 10 is absolute for ruling in, or fairly absolute, for ruling in a diagnosis. PND is only 2.6, so you really can't hang your hat on that. Likewise, orthopnea, swelling of the ankles. On physical examination, the only pertinent finding where you could hang your hat on to rule in heart failure seems to be an S3, very rare, even with electronic augmentation to try and bring out S3s. They're not that common. The chest x-ray, time and time again, the literature states in the best of circumstances, it's 80% accurate for the final diagnosis of COPD versus heart failure. And the electrocardiogram, though, has several features that can assist and support, and it's one of the pieces of the puzzle that Eric has alluded to. There's nothing absolute one way or the other than atrial fibrillation is more supportive for a patient in heart failure, but the likelihood ratios are not there to be useful.
I'd like to make a plea for people to really look at volume status carefully in the emergency department. So I don't think we do it very well in the emergency department. I don't think we do it often enough in the emergency department, but I think it's really of critical importance in patients who are short of breath to look at the JVP and see if it's distended or not. JVP will give you an immense amount of information on patients who are short of breath. If it's elevated, you have to think of heart failure, right-sided heart failure, with the most common cause of right-sided heart failure being the left-sided heart failure. It makes you think of pericardial tamponade, and of course it makes you think of pneumothorax too, but I think it's really important to look at jugular venous distension in the emergency department, measure it correctly in the proper body position.
And the science goes a step further, that if you were to apply hepatojugular reflex, it's even a touch more significant for ruling in acute heart failure.
Reviewing here about the importance of the history and physical examination in the diagnosis of acute heart failure, while it's really a constellation of signs and symptoms in combination with the chest x-ray and ECG that will give you the overall picture of whether this is heart failure or not, I'd like to just review some of the most important historical and physical examination features according to the JAMA, the Rational Clinical Examination series. The four most important historical features in terms of best likelihood ratios for acute heart failure are 1, a previous history of heart failure, 2, PND, 3, orthopnea, and 4, dyspnea on exertion. In terms of the physical exam, the four most important physical exam features for acute heart failure that have the best likelihood ratios are an S3, JVD, crackles, and leg edema. Again, there's very few of these that you can hang your hat on, but I think it is important to know which ones have the best likelihood ratios. One last note about the physical examination in patients who present in acute heart failure. When there is a low pulse pressure, this is a marker of low cardiac output and confers a relative risk of death of 2.5. A high pulse pressure, on the other hand, should trigger you to consider a high output cause of heart failure, such as anemia or thyrotoxicosis. Good. Let's talk a little bit about the ECG. Dr. Letovsky, I know you love to talk about ECGs. When a patient presents with suspected acute heart failure, what are the things that you're looking for in particular on an ECG?
So the ECG is a critical component of our ability to assess patients who are short of breath. It's rare to get a normal ECG, obviously, in patients who are short of breath, unless patients are short of breath because of anemia or neuromuscular issues. But most cardiorespiratory diseases will produce some kind of ECG findings, especially the cardiac causes of shortness of breath. Arrhythmias are one of the most common causes of congestive heart failure. Bradyarrhythmias, tachycardic arrhythmias, and especially atrial fibrillation. And patients who have a history of atrial fibrillation are prone to heart failure. So you're looking for arrhythmias, you're looking for ischemic changes, signs of ischemia, signs of non-Q wave infarction, signs of STEMIs even in patients who are diabetic or the elderly patients. And then you have to look at other evidence of hypertrophy, ventricular hypertrophy, or evidence of bundle branch blocks. Patients with left bundle branch block will have some left ventricular dysfunction. Patients who have evidence of left ventricular hypertrophy either have chronic hypertension that hasn't been treated adequately enough, or may have chronic valvular disease such as aortic stenosis or mitral insufficiency that cause the left ventricular or left atrial hypertrophy. So it's critical to look at the ECG carefully, which may give you a lot of information. Particularly patients who present with new acute pulmonary edema who may have a normal ECG but a new murmur, you might want to think of an acute mitral insufficiency, for example, as the precipitant for the acute pulmonary edema. It's seen in patients with mitral valve prolapse, for example. So the ECG is critical in the assessment of patients who are short of breath.
And the corollary of that is the evidence points that condition where you want to rule out heart failure, a normal electrocardiogram supports that. They state a likelihood ratio of 0.64. Of course, to rule out any disease, one wants a negative likelihood ratio of 0.1. This is 0.64, 1 being a useless test, right? So it's a bit more supportive. As Eric says, it's a piece of the puzzle. A normal electrocardiogram is more supportive for no heart failure, but something else.
The two ECG findings with the highest likelihood ratios for acute heart failure are atrial fibrillation and new T-wave changes. Okay, let's move on to the chest X-ray. How useful do you find the chest X-ray in diagnosing heart failure in the emergency department? And what aspects of the chest X-ray do you find the most useful?
I think the X-ray is of critical importance. I think you're looking for a number of features on the X-ray. First of all, you're looking for the positive signs of heart failure. You're looking for pulmonary vascular distribution in mild heart failure, curly B lines and interstitial edema in the more moderate heart failure, and the sort of bat wing alveolar edema in more severe heart failure. And then, of course, you're looking for, in COPD, you're looking for hyperinflated lungs, you're looking for perhaps a more narrow, smaller heart, and perhaps signs of pneumonia, which may have precipitated the COPD exacerbation. So, I think the X-ray itself is a very important tool. Sometimes it's hard to get a proper PA and lateral in the emergency department in patients who are critical. Sometimes we can just get a portable X-ray. Sometimes it's just supine, so it's often inadequate. But like the ECG, like the history, and like the physical examination, there's no single tool which either rules in or rules out heart failure from COPD. It's really the constellation of all the historical features plus all these diagnostic tests, which is really going to help you differentiate heart failure from COPD.
As we alluded to, there's COPD patients out there with congestive heart failure who normally have a chest X-ray that looks like a dog's breakfast, and they come in with an exacerbation, and we're looking for the signs, and I look for the signs that Eric has espoused. I think it's important to try and get your hands on an X-ray that this patient might have in your hospital, like a discharge X-ray once they were stabilized from a previous admission, and compare this presentation and this acute x-ray with their best looking x-ray.
One last point about the chest x-ray in patients with acute heart failure is that the x-ray in a small minority of patients may actually be normal. This is especially true if they present within just a few hours of flash pulmonary edema. It occasionally takes time for the fluid to show on the x-ray in any significant manner. Do you ever worry about giving bronchodilators to CHF patients?
No, not at all. You can see wheezing in congestive heart failure, as you can in COPD exacerbations, but if their patients are wheezing, it's because there's bronchospasm plus or minus bronchial wall edema, and I don't have any problems or reservations giving Ventolin bronchodilators to patients, even if they turn out to be congestive heart failure.
In fact, there have been studies around that support Eric's view around Ventolin, that kind of rationally you think if a heart is being stressed and you're going to put a beta adrenergic added to the scene, it's going to have a negative outcome on the cardiac status. But to date, the literature does not support that. So I think we all use shotgun therapy, but I think of all the medicines and the bullets we use with our shotgun therapy, bronchodilators are the most benign.
Unchain my heart, baby, let me be. Unchain my heart, 'cause you don't care about me.
Let's move on to BNP. Some researchers have suggested that the use of BNP in the emergency department may actually reduce hospitalization rates, reduce length of stay, help prognosticate, and possibly even improve survival in patients with decompensated heart failure. Yet there seems to be a lot of controversy around whether we should be using BNP in the emergency department to help diagnose heart failure. Without BNP, we're correct in the diagnosis of heart failure about 80% of the time, which isn't so great. A BNP of less than 100 has a pretty good sensitivity for ruling out heart failure, although probably most of those patients who have a BNP of less than 100, we probably knew already from the clinical picture that they didn't have heart failure. Conversely, when the BNP is over 500, it may help us to diagnose, to rule in heart failure. But again, most of those patients we probably knew had heart failure to begin with, and it might not help us. Where it's difficult is in those patients like the case that we're talking about, where we're not sure whether it's heart failure or something else. Some argue that the BNP will most likely be in the middle range in a patient who has intermediate risk, and so it doesn't really help us. Right now, presently, in 2010, there's very few emergency departments in Canada that actually have BNP. Dr. Steinhart, as a researcher in BNP, first, do you think we should be using BNP in the emergency departments in Canada? And if so, in what situations should we be using it?
So I'd like to skirt that question and just step back for a moment. Well, as we've been talking about, we'd like to get a little better with our accuracy because we're frustrated by history physical, chest x-ray, and electrocardiogram interpretation. We feel we need something more in the emergency department that can quickly help us as clinicians. So BNP has evolved. This stands for beta natriuretic peptide, and it's a hormone that is released from strained myocardium. And any cause of myocardium straining will elevate this hormone. It's called a hormone because we use it as a biomarker, but it is vasoactive. It actually has some pharmacological properties. In fact, it's been manufactured into a drug, a trade name Nasiritide. But we are talking about it in its diagnostic biomarker sense. So in the United States and elsewhere, it is standard of care to use either this natriuretic peptide, the class of peptide that we're talking about, or its cousin, quote unquote, N-terminal pro-BNP in elucidating and helping the clinician to rule in or rule out heart failure. And you've alluded to the fact that in many cases, the clinician knows the diagnosis anyway, the high probability heart failure or the low probability for heart failure, and we don't need a biomarker to help us. Our clinical acumen is pretty good, but you've also alluded to many studies that show when compared to a gold standard diagnosis for heart failure, we're missing about 20%, and that's in that group where it's the dog's breakfast, the COPD, pneumonia, pulmonary embolus, CHF patient that comes in short of breath. Like, how are we going to figure this out? And so I agree with your conclusion that in most of these cases, the biomarker is in that indeterminate range. Throughout the world, it's being used now in a categorical way, which means below a certain threshold of value, these results are negative for heart failure. Above a certain value, and you mentioned 500 for BNP. NT-proBNP has different units, obviously, and different levels. So that's positive for heart failure. And we as clinicians want the quick answer, as does any professional. We want to know quickly a test that will tell us we don't have to go any further. We can start treating this patient definitively, appropriately. We don't have to shotgun them anymore. And we want a test that'll say yes or no to us. That's the heuristic approach to critical thinking, and it's just a natural consequence of slugging it out in the emergency department day or night and trying to get volume through and on all the pressures that we have. So that's why BNP exists. Unfortunately, it's not that accurate to rule in, even when it's above the suggested rule-in levels. The likelihood ratios for BNP that you quote at 500 is somewhere in the order of 4. In fact, a meta-analysis by Andrew Worster, our colleague in McMaster, of all the literature for BNP and NT-proBNP, of all the literature in the world, when he summarizes it, both BNP and NT-proBNP have a likelihood ratio of 3 to rule in heart failure. That's an amalgamation of all the science to date. 3 is not 5 and it's not 10. It's not 1, but it's not great. So to use it in its traditional categorical way, I think, is being overgenerous to its performance parameters. And I don't support its use that way.
Dr. Steinhart was the lead author on an article out of the journal American College of Cardiology, 2009, volume 54, issue number 16, called Improving the Diagnosis of Acute Heart Failure Using a Validated Prediction Model. This paper, I think, really helped us with those patients who are in that gray zone, in the intermediate zone. And Dr. Steinhart here will explain the paper to us and what his take is on it.
Anton, what we did is we took a Canadian study that had analyzed NT-proBNP in a traditional use, and we took the raw data and just looked at its absolute values, and we tried to combine it with a clinical parameter and see where we get with diagnosing or ruling out acute heart failure. But we decided to, keep it simple, stupid, the KISS principle, and just get the doc's pre-test probability. After history, physical, EKG, chest x-ray, what did the doc think was the chance of this undifferentiated, shorter breath patient have for heart failure from 0 to 100? And we used that parameter, and we used the absolute value of the NT-proBNP, not positive or negative or indeterminate, just whatever it was, 2 to 20,000. And we threw it in a mathematical blender, and we came out with a prediction model probability for heart failure. And we found when we compared it with the ultimate gold standard that we have available today, which is adjudicated diagnoses, some 60 days post-index visit, we found that when the doc really thought it was or wasn't heart failure, the model didn't do any better than the clinician. But when the doc was in that gray zone, the pulling of the hair kind of gray zone, I think it's called gray zone because the doc's hair turns gray, and that's why I have so many gray hairs. But in that critical subpopulation, 50% of the time, the model appropriately redirected the doc to say, no, it's not heart failure, or yes, it is heart failure. And in the other 50%, it said it couldn't help, but it did not hurt. It did not mislead. So it's kind of a novel approach to using this information. It's a mathematical model. It uses clinician gestalt, and it's worthy of prospective trial.
So just to clarify there, everyone who's complaining that in these patients that we need something to help us diagnose it the most, where these patients that we're not sure whether it's heart failure or something else, they're all saying that BNP really doesn't help. Your study is saying 50% of the time it'll change our minds from this indeterminate gray zone to, yes, this is heart failure, no, this isn't heart failure, and we'll be right.
Well, it might help. I think it's too generous to say it will help. It needs prospective validation to say that. I have to tell you, the science repeatedly has shown ROC curves that shows benefit for using BNP in its traditional sense. My model is not its traditional sense, right? It's a continuous variable. But the science, including Canadian data, has these ROC curves that show definite improvement in clinical diagnosis using BNP, definite savings of money and decreased hospital readmissions, not mortality, by the way.
I see. How much does a one BNP test cost? You know?
Well, if you buy one case, it's around $40, and I'm referring to NT-proBNP. BNP is cheaper, but if you buy a lot, or there are centers now that have it in $18 per sample.
So not too expensive.
It's not the cost of a CT scan or an echo or other tests that we might have to go on to.
On the other hand, it's not the cost of a sodium or a CBC. It's not insignificant. You in a department like ours, we see 250, 270 patients a day now. How many of those patients present with short of breath? Now, I'm speaking as an emergency department director now. I'm wearing my hat right now as emergency department director. Without convincing data that BNP helps in the emergency department clinical decision making, without more and better data suggesting its usefulness, it's not something that I've adopted right now. My fear is that as soon as you allow emergency physicians to get a test, or any kind of physicians to get a test, the natural tendency, for whatever reason, is to use it. My concern is that for the 25 patients who present to my emergency department with shortness of breath, there's going to be 20 BNPs ordered, probably 18 inappropriately. That's a lot of money. It costs over 365 days a year. That's a lot of money. These days of cost-containing, restricted budgets, we're talking a lot of money, I have to tell you, for a test that really just hasn't given us a lot of bang for our buck.
Just to be devil's advocate, I know it's not part of my persona, but Eric mentions it's not like sodium and CBC. But the very point is, how useful is a CBC and a sodium, right? And how many thousands of CBCs and sodiums do we order a week?
Sure, I guess it goes to
the general... So there's a balance, right?
The general principle.
This is the new kid on the block, and I understand and I support the trepidation that goes on with a new kid on the block. And I think it should be trialed in a very restricted, close manner, and let's see what we get.
And there may be a role for it at some point, but I think maybe perhaps as an adjunct to everything else we depend on, the history of the physical examination, the chest x-ray, and the ECG, and not to replace those important parts of the assessment that we have to depend on.
Unfortunately, the cardiologists who are the prime stakeholders in this even the academic ones who agree with what Eric and I are saying still would like a index visit BNP, NT-proBNP value more for their baseline, for their maintenance of therapy. There's BNP and NT-proBNP, as you know, is not just for diagnosing or not diagnosing acute heart failure, but has shown some scientific evidence for being a benefit in maintaining these patients and what's the right therapy and adjusting therapy for ongoing months, several months down the road.
That's
comparing,
monitoring their progress
so
in
for
heart failure, because
exactly.
once established.
Right.
Correct.
So for that reason, they're saying, you know what, draw it in the emergency room, and so we could get the baseline value. But then it has a distinct chance of being abused by our colleagues and by us because it's there, and that's the natural tendency.
Okay. And perhaps it may have a role in, once the diagnosis of heart failure is established, we still don't have a good tool for prognostic purposes to determine which patients are safe to discharge and which patients need to be admitted. So perhaps it could be looked at as part of a larger prospective trial to develop a tool for that kind of prognostic importance.
Help on the way. Well, I know I'm an inside God.
Which patients do you order a troponin in who present with heart failure?
So your question is, which patients do I order troponin on? Patients who have heart failure? It's easy. All of them.
All of them?
Absolutely. You have to remember that one of the causes of acute pulmonary edema is ischemic heart disease, acute decompensation of contractility because of ischemia. Remember, think of the causes of congestive heart failure: increased preload, increased afterload, arrhythmias, and contractility issues, primarily because of ischemic heart disease. A lot of patients, our older folks and diabetics, present with atypical symptoms of ischemia, just shortness of breath alone. The elderly, as a manifestation of their myocardial infarction, present more with shortness of breath and chest pain. The elderly often present with silent ischemia. I order troponins on all patients with acute congestive heart failure.
Certainly makes sense, but unfortunately, congestive heart failure alone can bump your troponin, right? So then you're in between a rock and a hard place. I agree with what Eric has said. I try and be a little bit more judicious. Certainly the elderly with new onset heart failure, anyone with new onset heart failure, they get an appropriate timed troponin. Of course, we have to keep in mind in the background, as I alluded to, troponin is released from damaged myocardium. But it could be damaged from any reason, right? Not just ischemic heart disease.
As you were alluding to, Dr. Steinhart, the troponin may be elevated just on the basis of CHF alone.
Correct. You don't know that. In an emergency department, you're not going to know whether the troponin is because of a primary ischemic heart disease or secondary to the left ventricular dysfunction. There's no way you're going to know that in the emergency department, unfortunately.
In of itself, of course, like BNP, for whatever reason, assuming it's not due to a spurious result or decreased renal clearance, or a rise in troponin is a bad thing for whatever reason, right? I mean, there's no doubt of all the controversies around troponin. The higher your troponin is, for whatever reason, for whatever your presentation, it's more morbidity, mortality down the road.
Right.
But how do we act on that? Talk about guidelines and prediction models. There's nothing to lead us on how to deal with this one value.
Yeah, I believe there was a study that reiterated that or elevated troponin, for whatever reason, significantly increased your mortality.
Correct.
So
troponin goes up in sepsis. It goes up in post-cardioversion, in renal patients. It may be elevated, whatever, but it's a marker for bad outcome.
Yeah, I mean, we're often hearing from the specialists, well, the troponin is elevated because they're in renal failure, obviously, and so why should I admit the patient based on that alone? And so I usually tell them about this study that.
Right. Well, as you know, the studies say it's not decreased GFR, if we're going to go to troponins, it's not the decreased GFR that affects the rise in troponin I. Troponin T, yes, but troponin I is raised in the uremic patient because of subclinical uremic cardiomyopathy. It's that irritation, right? They're prone to pericardial effusions and whatnot, and it's that irritation and inflammation that is affecting the epimyocardium that is thought to cause the chronic elevation in this patient cohort, not decreased GFR.
When working up a patient for heart failure in the emergency department, it's important to understand that about half of these patients will have a known precipitant. Some common ones include a change in salt intake or a change in medication. Some of the causes of heart failure need to be identified and addressed quickly in the emergency department, such as ischemia, cardiac arrhythmias, severe hypertension, and valvular dysfunction, for example, a mitral valve regurgitation from a papillary muscle rupture. Other causes to think about are cardiomyopathy, especially in the peripartum period, and associated with thyroid disease such as thyrotoxicosis or myxedema coma. And lastly, it's important to think of myocarditis as a cause for heart failure. In the next little bit, we discuss the oh-so-popular subject in emergency medicine of ultrasound. Here we're going to talk a little bit about formal ultrasound and bedside ultrasound.
But an echo soon, very soon, rather than later, would be important because we miss critical valvular disease. We just don't hear it. It could be so tight, like an aortic stenosis, that we don't pick it up.
So in what situations would you push for a formal echo in the emergency department for your heart failure patients?
So I'll give you an example. A couple of months ago, I had a young male who presented with congestive heart failure, young male with no past medical history, on no medications, with an ECG that was essentially normal besides a slight tachycardia that showed no evidence of hypertrophy or any evidence of left ventricular strain, so no evidence of chronic hypertension. So why is a young male in acute heart failure with no evidence of hypertensive heart disease either by history, by physical examination, or ECG? So he was somebody who I called my cardiologist to do an emergency echo. In fact, he had acute mitral insufficiency and needed to be transferred to the center for acute valvular surgery. So that's typically the kind of patient who really needs an urgent echocardiogram. The other patient, obviously, who needs an urgent echocardiogram is the, again, patient who present with new murmurs in the signs of ischemia. For example, patients present with acute inferior infarction, can disrupt their mitral valve, leading to acute valvular insufficiency. And again, those patients need urgent transfer to a center that can do valvular repair in the setting of a post-infarct patient. So certainly in the presence of any new murmur, and it's difficult to listen to murmurs to the heart in the setting of an emergency department, but it's really, really critical that you get the patient in a quiet area where you can listen to a new murmur.
Do you think there's a future for bedside echo in the emergency department for helping us diagnose the causes and whether the patient has CHF or not for bedside ultrasound?
About 50% of patients with acute heart failure have systolic dysfunction, which you can pick up on an echo. It's nice to know. 40% of them have diastolic dysfunction, which you could pick up on an echo, but you need to be a really slick echocardiographer, and you need to have a really good machine, and everything has to be optimal. And even then, there's inter-observer variability. So echo will support the diagnosis for acute heart failure 90% of the time. We're not going to do anything different, whether it's systolic dysfunction or diastolic dysfunction. We in the emergency department are not going to do anything per se different because of that. It's not going to change my management immediately. And to get an emerge doc who hasn't gone through 2 years of echocardiography training and certainly doesn't have the multi-million-dollar machine that they have up on the cardiology floor, I see no immediate future for that.
I think patients who present with shortness of breath, NYD, need a quick ED echo by the emergency physician to rule out pericardial tamponade, especially if there's distended neck vein. So I think there's some value there. It's a diagnosis that's easy to make, and I think it has really important therapeutic implications, making a diagnosis of pericardial effusion quickly in the emergency department. Looking for ventricular function in the emergency department, I think at this point in time is beyond the scope of practice for emergency physicians. I think the ventricular function is subtle. You can really be misled by contractility, thinking that it's normal when it really isn't. So my personal belief is that's beyond the scope of emergency medicine at this point. But I do think it's worth looking at to look for pericardial tamponade. But beyond that, I think a proper echocardiogram done by the proper cardiology staff is what's important in patients who present with new acute pulmonary edema.
But in no way should we think of an echocardiogram, regardless of who does it, as being the gold standard for ruling in or out acute heart failure, right? There are many, many, many elderly people walking around who are perfectly fine with systolic dysfunction or a bit of diastolic dysfunction, and they may present with a pneumonia, and you may pick up their incidental ventricular dysfunction, and to be misled by, quote, a positive echocardiogram would, again, be suboptimal for the patient. The corollary is also true. As we said, there are many patients who come in with diastolic dysfunction as a cause of the shortness of breath that will not be picked up on an echo immediately by an echocardiographer. So you get false positives and false negatives.
It's time for a little bit of Canadian trivia. Here goes the question. Which Canadian actor wrote himself a check for $20 million and carried it around in his pocket until he earned that amount in one film? You guessed it, comedian Jim Carrey held on to that check until he earned $20 million for his work in Cable Guy.
You know, I used to get really upset when I told people where I came from down in Los Angeles because I always got the same response. Canada? Wow. Must have been cold. Now I just go along with them.
Yes, Canada. It was a frozen, hostile wasteland. And there was much work to be done if we were to survive the elements. After boring a hole through the ice to find food, my good friend Nantuck and I would build an igloo to protect ourselves from polar bears and flying hockey pucks. Then we would drink a lot of beer. And when Nantuck was ready, he would tell me the story of the great moose who said to the little squirrel, "Hey, Rocky, watch me pull a rabbit out of my..."
On to the second part of this episode. We're going to concentrate now on the management of acute heart failure. Over the last several years, leaders in the heart failure community have been reconsidering how diuretics, nitrates, and inotropes should be used in heart failure. It's surprising that there's very little good data that will tell us who requires these medications, what dosing should be used, and whether they significantly affect long-term outcomes or not. The classic teaching is that acute heart failure is an acute event involving fluid overload, systolic dysfunction, and low cardiac output. However, registry data have shown that acute heart failure population is not this homogeneous group of chronic heart failure patients, but rather different types of heart failure patients with various forms of acute decompensation, combinations of comorbidities, and varying degrees of severity. There are a lot of different classifications for heart failure. There's high output versus low output, right-sided versus left-sided, forward versus backward, systolic versus diastolic, and none of which seem particularly applicable to emergency medicine practice. Over the last few years, a model for how we should approach patients with acute heart failure and that helps us guide our therapy with more finesse and may help to prevent serious morbidity and mortality. It divides patients based on their presenting systolic blood pressure. So those who have a systolic blood pressure higher than 160, those who have a systolic blood pressure between 120 and 160, and those who have a systolic blood pressure less than 120. And it suggests specific therapeutic algorithms based on these different presentations. So in the second section of this program, we'll discuss this practical approach to the management of acute heart failure, as well as go over the rationale and value of each of the therapies for acute heart failure. So we'll start with a case. An 80-year-old woman with a history of hypertension and obesity comes in by ambulance at 2 a.m., shortly after experiencing a sudden onset of shortness of breath that woke her up from sleep. She denies any recent illness, but does admit to eating a very salty meal at a fine restaurant the evening prior. She has no chest pain, cough, or fever. She has no ankle swelling, no calf pain or swelling. She has no thromboembolic risk factors and denies a history of smoking or of COPD. She takes Norvasc for her hypertension. On exam, her blood pressure is 180 over 110, heart rate is 115, respiratory rate is 28, O2 sat is 90% on room air. Her chest exam reveals good air entry bilaterally with crackles to the mid-scapula. Her JVP is not visible. Her heart sounds are normal with no murmurs. There is no pedal edema. The ECG shows sinus tachycardia with no ST changes. A stat portable chest X-ray reveals no obvious signs of CHF.
So you're going to move this lady into a resuscitation room, obviously. You're going to get an IV into her. You're going to give her 100% oxygen. I hate when people play catch-up with oxygen. People start with 28, then 35. Patients in acute respiratory distress need a maximum amount of oxygen. So I like to start these people on 100% oxygen while I'm examining them. While we're getting the ECG and the X-ray, all this kind of stuff. And you're giving us all the information, but a lot of the assessment and treatment is done concurrently with your investigation, because it often takes a couple of minutes for the portable X-ray to be done and for the ECG to be done. So, if your initial assessment is that this lady's in acute pulmonary edema, and it sounds like she is, she's probably a Killip 2 heart failure, and you think that she's probably not terribly volume overloaded, but she still may be slightly volume overloaded. I think I'd maximize the oxygen, and depending on how ill she looked when I walked into the room, if she was in a lot of respiratory distress, I put in a stat call for my respiratory therapist to come down and to assist with, possibly BiPAPs, initiating BiPAP already. At the same time, I'd give this lady a nitrous spray to start some preload reduction. And while I got a bit more history and did a bit more thorough physical examination, so I'd get my RT, I'd get my BiPAP, and depending if she really looked unwell, I'd have the RT put the BiPAP on it almost immediately. I'd give this lady some nitrates, start with some legal nitrates, with a view to probably starting an intravenous nitroglycerin infusion on this lady already because of how severely hypertensive she was. That would be my initial management, but then I may go on to manage her with diuretics at some point, maybe not immediately. If she was really tachycardic and diaphoretic and looked unwell, I don't think the diuretic would necessarily work right away. But because she's so hypertensive, and it was the precipitant, most likely precipitant, the increased afload and increased systemic vascular resistance is most likely precipitant. I'd maximize the oxygen, try to maximize the ventilation with BiPAP, and decrease preload and decreased afload with nitrates.
So Lasix wouldn't be your first drug in this patient?
Well, I'll tell you something about Lasix. And if she really looked unwell, she's clammy, she's diaphoretic, she's got a lot of sympathetic overdrive. The problem with furosemide is that it works by targeting a single organ, the kidney. And when you have a lot of sympathetic overdrive, you tend to shunt blood away from the splanchnic and the kidneys to more important organs, right? Heart, lungs, brain. And so you decrease perfusion to the kidneys. And in the kidneys, you need adequate glomerular filtration for the furosemide to work. So it's not like I wouldn't use it. I may, in fact, use furosemide, even if I thought she was euphalemic. I still might use Lasix, but I don't think it's going to work right away because of the sympathetic overdrive. You're not perfusing the kidneys very well. It simply isn't going to work right away. So I often wait for a little while until I get the nitrates down to decrease preload. And my preference would be to start BiPAP and nitrates aggressively on this lady even before I start the furosemide.
Okay, Dr. Steinhart?
I would largely concur with Eric's approach. I would have liked to have seen a chest X-ray that's somewhat supportive of fluid overload, but if we assume this is heart failure, I'll throw a wrench in the works and say I would probably include some morphine.
Okay, why don't we talk about morphine for a bit? So my understanding is that there has been some evidence that morphine actually increases the rate of intubation and possibly increases mortality in acute heart failure. So I usually stay away from morphine altogether in heart failure. I prefer to use benzodiazepines if the patient appears very anxious, which doesn't have any cardiac depressant effects as far as we know. So Dr. Steinhart, what's your thinking with using morphine?
I have a lot of experience with it. It was a mainstay drug when we started our careers. That's not to say that it's a good drug. And I will admit that there's no evidence that clearly supports its pharmacologic use in this disease entity. However, I take exception that there is evidence that it is a bad drug. Again, because you're referring to the ADHERE registry, and for all the limitations of the ADHERE registry, when you drill into it, and this is the main landmark study that from which you're quoting from, in the registry, they use doses 30, 40 milligrams over 12 hours. I'm talking about 3 to 4 milligrams one time, maybe repeated an hour later. And then they don't even separate out the confounders. For example, how many of these patients with heart failure actually had severe chest pain and an ACS, and you were giving them morphine as much for their pain control as it was for their heart failure? They didn't tease that out in the synopsis of the ADHERE registry. So I'm not swayed by any literature from the ADHERE registry. I think it helps. I'm quite sure it doesn't hurt the patient, and it makes me feel better.
Yeah, the reason I would stay away from morphine in this particular patient is that I'm already starting one drug which decreases preload. I'm already starting nitrates. I'm going to titrate the nitrates up pretty high because at higher doses you get afterload reduction, which is what I'm looking for in this particular patient. But I'm already giving a drug that decreases preload, decreases afterload, and I'm also starting BiPAP on this lady right away. So yeah, I agree with Brian. I've used morphine lots of times in the past. I just wouldn't use it in this particular scenario because I'm starting the BiPAP and another drug for preload reduction.
This patient did receive nitroglycerin and BiPAP and still persisted to have signs of pulmonary congestion. What would be your next move?
So I think you're raising a very appropriate point with nitro. And that is, it's difficult to use. As Eric says, you got to start somewhere, and I start with sublingual nitro. In fact, so I actually give it to the patient sometimes if it's suitable, because the nurses can be very busy and it's labor intensive. I say, here, take a squirt every couple of minutes, and then I start an ART line if we're not getting anywhere, solely to have minute by minute instantaneous blood pressure monitoring, so I could free up that nurse and continue my nitroglycerin, because then you're going to go to intravenous nitroglycerin, and intravenous nitroglycerin, you start around 30 mics a minute. Some people start lower, some people start higher, some people titrate quickly, some people don't, but you may have to get to 160, 200 mics a minute to gain any effect. And I'm not sure where you're at with this patient, but I'll tell you, none of our nurses are going to stand by there and Q5 minute increase the nitro drip unless that patient's in extremis. We just don't have that kind of dedicated nursing staff. That's the challenge with going with intravenous nitro and ramping up to a suitable level. It can take a lot of time.
Yeah, I find in numerous times I've written an order for increasing the nitro by 10 mics every 5 minutes. And inevitably I come back 20 minutes later, half an hour later, 40 minutes later, and the nurses never seem to want to go up above 50 or 60 mics.
Which is, I think, it's why it's so important to initiate BiPAP early in these patients.
Yeah,
I think you have to be really aggressive. You know, I think that BiPAP has really revolutionized the treatment of acute pulmonary edema in the past 15 years. You know, 25 years ago it was common for Brian and I to intubate patients with acute pulmonary edema.
That's where I gained all my skills.
Exactly. So for me to intubate a patient with heart failure now is a very, very rare phenomenon. Since the introduction of BiPAP, it almost never happens. You know, I'll sit there, even with patients who are really looking unwell, you know, you think they're going to code, they're diaphoretic, they're clammy, they're sitting at PCO2s at 60, 70, 80, and you put them on the BiPAP in 10, 15, 20, 25 minutes, they just get gradually better and better and better. They ease the work of breathing. The nice thing about BiPAP is that it just maintains the alveolar patency at end expiration, so the patient doesn't have to work so hard to open up the alveoli in inspiration. And not only that, when there's a lot of fluid in the lungs, when there's a lot of fluid in the alveoli, when they have a lot of RAL, they have a lot of fluid in the alveoli, what the fluid does, it kind of dilutes out the surfactant and makes, you know, the surfactant incapable of maintaining the patency. So by keeping alveolar patency, it eases the work of breathing, improves oxygenation, improves gas exchange, and improves cardiac output as well. I mean, this is the kind of patient you don't... the worst thing you can do is gradually become more and more aggressive in these patients. Then you've lost time, and what you want to do is be aggressive as possible from the first minute.
And do you have a preference between BiPAP and CPAP?
Yeah, I mean, we use BiPAP. I mean, you could use CPAP. There's no reason why you couldn't use CPAP. And if you were in a small hospital that didn't have BiPAP machines and only had access to a CPAP machine, you could use CPAP. The nice thing about BiPAP is that while CPAP is static, BiPAP gives you dynamic pressure, positive airway pressure. So it just mirrors normal physiological respirations better, right? So it's more comfortable for the patient. That's the only reason you use BiPAP as opposed to CPAP. So in inspiration, it's one pressure. Expiration, it's a lower pressure. So it's just easier. It's more comfortable for the patient. But you could easily use CPAP for a patient with acute pulmonary edema. If that's the only machine you'd had, absolutely you'd use it. It would just be more cumbersome for the patient. It'd be harder to tolerate. That's all.
Okay. Going back to the case here, the patient received nitro, BiPAP, and still had evidence of pulmonary edema, then received diuretics, intravenous furosemide, and ended up improving soon after that.
Yeah, so that's the rationale, is that you want to wait until the acute respiratory distress is over before you really want to give the furosemide, because it just isn't going to work. So what I usually do with these patients, let them settle down, let the BiPAP work, let the nitrates start working by decreasing the preload, and let them become less diaphoretic and clammy and decrease the sympathetic output, and then you can give the furosemide and you'll get prompt diuresis after that.
See, in our earlier days, we wouldn't need to go there because we would have phlebotomized and provide rotating tourniquets, which basically does, you know, in a crude sense, the same as Lasix, right? It just takes the fluid away from the heart. You know, it's just a fancier way of using Lasix. Thank God we don't have to do that anymore.
Yeah, you know, I think when you're treating a acute pulmonary edema patient, it's in the back of mind, you really have to think of the causes of heart failure. Increase in preload, increase afterload, arrhythmias, or pump problems. Those are the four causes of acute congestive heart failure. So you have to reduce preload. Patients who are very hypertensive, evidence of high systemic vascular resistance like this patient, you've got to reduce afterload. You've got to correct any arrhythmia. And then if there's evidence of cardiac dysfunction, whatever you can do in the emergency department, it's not much. You can increase cardiac output with the use of BiPAP. But those are the causes of congestive heart failure. So you've got to decrease preload, decrease afterload, correct arrhythmias, and help the pump however you can.
The outcome of this patient was she got much better. She had a normal ECG. She diuresed, and she ended up being consulted to the internist on call. So let's go on to another case, and then we can compare and contrast the two cases. Second case. A 60-year-old male patient presents to the emergency room from home with progressive increase in breathlessness, orthopnea, and ankle swelling over the previous 3 weeks. He had suffered from dyspepsia and a wet cough increasing over recent weeks, and the family physician had noted a new murmur. He denied a history of chest pain, back pain, or shoulder pain. His past medical history was remarkable for CHF and an MI. His medications were aspirin, Lasix 40 milligrams every morning, Altase 5 milligrams once a day, and metoprolol 50 milligrams BID. On exam, he appeared in moderate respiratory distress. His blood pressure was 125 on 60, heart rate of 110, respiratory rate of 28, and an oxygen saturation of 88% on room air. His temp was 36.8. He had marked pedal edema, hepatomegaly, and JVD with bibasilar crackles. He had a pansystolic murmur heard best over the apex. The ECG confirmed sinus tachycardia of 110 beats per minute with anterolateral Q waves and no ST changes. The chest x-ray confirmed cardiomegaly and interstitial edema. Previous echocardiography showed a dilated heart with anterior and septal hypokinesis and apical dilatation compatible with the previous anterior infarction. Routine chemistry showed a sodium of 128, a potassium of 5.8, urea of 9, and a creatinine of 155. Dr. Steinhart, how would you manage this patient, and would it be any different than you would manage the first patient?
Well, we have only so many tricks up our sleeve, and so one would consider here whether we should start with a diuretic immediately. The patient is wetter than the first case. The pressure is acceptable. Maybe we could drop it a bit, but I would likely be more aggressive with the diuretic earlier on, and the nitroglycerin or some sort of vasodilator more secondarily. The problem, of course, is the patient is already hyponatremic and azotemic, and this ADHERE registry shows clearly that at least 30% of patients who present with heart failure are azotemic, and there's clear association between diuretic use, increased serum creatinine, and mortality. So we have to be judicious, but I think currently, and certainly the Canadian Cardiovascular Society guidelines currently say give this patient 80 milligrams of Lasix via a saline lock and support the ventilation otherwise with oxygen, if not getting BiPAP going quickly. I agree with Eric. Sooner is better than later with this kind of patient for non-invasive ventilation, unless you want to practice your intubation skills. And start with some nitro, but the patient, I think, needs a diuretic immediately, knowing that it may take a period of time, if not some tachyphylaxis and resistance might be more in this kind of patient to a diuretic, so get it in early.
This is a bit of a diagnostic challenge, this gentleman, for a number of reasons, and I'm worried about him, not only because he's so hypoxemic, but also because he's got a new pansystolic murmur, which suggests, does this guy have an acute new mitral insufficiency murmur for whatever reason, on the basis of, you always have to worry that he's got some silent ischemia, which has now caused a rupture of the mitral valve here. So I'm very worried about this guy. I think this guy is sicker than he looks, to tell you the truth. Despite the fact that he's normotensive now and he's only 110, this guy is a sick puppy. I think you need to maximize your oxygenation, maximize your ventilation. I would start BiPAP on this guy immediately, because your therapy, because you're between a rock and a hard stone with diuretics, morphine, and drugs to decrease preload, decrease afterload in this guy. So I think it's essential to start BiPAP on this guy if you have BiPAP capability to decrease the work of breathing, increase your cardiac output in this guy, the essential with this new murmur, whatever is going on there. He clearly has evidence of biventricular failure. He's got the RALs and he's got the peripheral edema. So he's got evidence of biventricular failure for either on the basis of the ischemia or the new valvular dysfunction superimposed on his ischemic heart disease. So maximize oxygen, maximize ventilation with BiPAP. I would give him, despite the fact that he's got a high creatinine and a low sodium, I'd still give him a diuretic. And I think this is the kind of guy that you need to get to your coronary care unit or ICU quicker than later because he's got an urgent echo. He's probably going to need some lines. This is a guy who could decompensate very quickly on you.
So we've discussed a little bit about when you would use diuretics. In terms of dosing, it doesn't seem like we really have any good guidelines of what kind of dosing we should be using, whether we should be using an infusion or just boluses. There is some evidence that infusion might be better than bolus furosemide. And there's take their daily oral furosemide dose and use that as your dose, as your bolus IV dose. What do you usually do in terms of dosing your furosemide?
Well, there are no guidelines. That's what you're alluding to. In fact, there are no emergency medicine guidelines as to what the initial dose should do. I use that. I usually take what their total daily doses is and start that intravenously. And if there's no response in 30 to 60 minutes, then I'll double it. But there is no consensus on what the initial emergency medicine diuretic dose should be. But I think most of us would probably think that's a reasonable approach to take the daily dose and just give that intravenously.
There have been some studies showing that high-dose furosemide increases mortality and that we should be using lower-dose furosemide in the emergency department. I find it a really hard clinical conundrum when you have a patient with renal failure where you know that giving the Lasix may increase their mortality, but at the same time, you know that you need higher doses that you normally give to diurese. Again,
those are the patients you know are going to be volume overloaded, though, right? Those patients are volume overloaded. So again, think about your causes of heart failure. And the first most common cause is increased preload. So again, do everything you can to decrease preload. Nitrates, for example, really temporize you well, especially in those dialysis patients who are waiting for dialysis. Nitrates to decrease preload and decrease venous return.
So you're referring to, of course, they'll put a label on anything now. What you're referring to is the cardiorenal syndrome as opposed to the hepatorenal syndrome. And there's an association with diuretic use and renal failure and increased mortality. So the nephrologist's current frame of mind is, well, you can't do anything different in the emergency department. They'll come to dialysis, right? They'll just get progressive renal failure because what else are you going to do? And the ER doc's traditional point of view is, well, we got to squeeze water out of a rock somehow. And many people aren't even aware or sensitive to this syndrome because it happens downstream, right? If they were to die in our emergency department, we'd be a lot more aggressive about changing or trying to change the way we do things. But we don't see the rise in creatinine in our emergency department. It happens, days later, and they're not in our emergency department. And so it's a downstream effect. But certainly aside from this dose trial showed no change in creatinine. It's the first study, if you want to believe it at all. Again, it's not published yet, so I haven't had a chance to drill into it. From what I understand, there was no change in serum creatinine, regardless of which way or how much diuretic you gave, regardless of if the patient was presented azotemic or not. This is revolutionary. This goes against all other trials that support exactly what you said, Anton.
In terms of patients who present with very high blood pressure, you've started your IV nitroglycerin and you've ramped it up to 150 mics per minute, but still they have high blood pressure. What do you do next?
So it's a difficult challenge. I mean, you don't see that very often. I mean, perhaps you're talking about a hypertensive emergency now, in which case that's the kind of patient who really needs to go to the ICU and, perhaps be on a nitroprusside drip. Obviously, if they're in acute heart failure, you want to avoid beta blockers. So beta blockers are contraindicated in that particular patient. I think that's the kind of patient who really needs to go to the ICU for lines and nitroprusside and therapies really beyond what you should be doing in an emergency department, is my perspective.
To open a can of worms. There are now, in many centers, using intravenous ACE inhibitors in the emergency department. They're actually even using now, trialing intravenous calcium channel blockers with ultra short half-lives. And in Canada, we are conservative, both in the emergency environment and with the cardiology community, in that there are no good trials supporting intravenous ACE inhibitor use in the emergency department for heart failure patients at this time. But it does make sense. The apprehension is the potential negative inotropic effect. And that's why they give it on the floor, by mouth, PO, some period of time after the patient has presented, typically hours, usually less than 24 hours from presentation. But this would be something to consider, as Eric says, not in the emergency environment.
In the States, I know they use IV enalapril and sublingual captopril.
Right.
What do we have?
With props maybe increased morbidity. I think you have to be very careful. And don't forget, a lot of these patients, for example, your second patient, most of these patients who have heart failure are already on an ACE inhibitor. They should be, especially if there's any renal dysfunction. They should be on an ACE inhibitor as well. So then adding an ACE inhibitor in the emergency department is probably going to be of minimal benefit if they're already on ACE inhibitors at home chronically.
So as you've heard, the approach to these two cases are very different, and they are representative of this model of heart failure, which divides patients into those who present with high blood pressure and those who present with normal blood pressure. In terms of the patient who presents with high blood pressure, they are usually the acute pulmonary edema patient, and they represent about half of the acute heart failure patients. These patients tend to be older, they tend to be women, they tend to have a history of diastolic dysfunction, and they often have symptoms that present acutely over 24 to 48 hours. Because of the shorter onset of symptoms, they're much more likely to have acute pulmonary edema, both on exam and on the chest x-ray, rather than having systemic edema, which would present with weight gain and leg edema. Pathophysiologically, the symptoms are usually the result of a significant increase in afterload and fluid misdistribution rather than total body fluid. They have pulmonary edema, crackles, and minimal weight gain. Usually they have preserved systolic function. These are the kinds of patients that you want to treat with nitrates up front. And then if they're volume overloaded, you can add the diuretic. And these are the patients where nitrates will work very well to decrease the preload and the afterload. And these are the kinds of patients that you're usually going to IV nitroglycerin on. In contrast, the normotensive acute heart failure patients, they usually present with mild subacute worsening of their symptoms over several days or weeks. They tend to be a bit younger and they tend to have systolic dysfunction, and a lot of them have a history of coronary artery disease. Their symptoms are generally a result of gradual total body fluid overload as opposed to the pulmonary congestion causing respiratory distress from acute hypertension. These normotensive patients tend to present with peripheral edema plus minus pulmonary edema. They tend to have a gradual onset, they tend to have a lot of weight gain, and they tend to have decreased systolic function. These are the kinds of patients that you want to treat up front with diuretics and consider nitrates in addition. Going on to the specific medications that we use in the emergency department for acute heart failure. For diuretics, there is some evidence, not the greatest evidence, but there is some evidence that continuous infusion is better than bolus IV diuretics. Lasix does take about 45 minutes to 2 hours to really start working. So you can't expect it to start working very quickly in these patients. As many as 40% of patients who present with heart failure have intravascular euvolemia or hypovolemia. And this is why, for these patients, Lasix can be dangerous in terms of worsening renal function and possible increased mortality. Therefore, for patients who are euvolemic or hypovolemic, diuretics should be used very judiciously in these patients, and their electrolytes should be followed carefully. There was one time I was speaking to one of our intensive care colleagues, and we had this case where we weren't sure whether it was CHF or whether it was pneumonia, and the patient's blood pressure wasn't that great. I was asking him about whether we should be giving Lasix or whether we should be giving fluid in this patient, and worried that if we gave him Lasix, that his kidney function would worsen, and if we gave him fluids, then if it is heart failure, then his heart failure would worsen. And he told me that from an ICU perspective, they'd always much rather have you fluid overload a patient than dry a patient out and have their kidneys filled up. If you're ever in that situation where you're not sure whether the patient has pneumonia and might be on the verge of sepsis versus a patient who you might think has CHF, he suggested that you give fluids and see what happens. If you give fluid and the patient goes into worsening heart failure, then you can always back off and you can always give Lasix after that. Moving on to nitroglycerin, I just want to reiterate that very high doses are often needed, especially in these hypertensive patients. Sometimes, in order to get good arterial dilatation, you need somewhere in the range of 200 mics per minute infusion. In terms of what we need to watch out for in nitro, patients who have a history of aortic stenosis or pulmonary hypertension, we have to be a little bit more careful with nitrates because these patients are very dependent on preload to maintain adequate blood pressure. As far as ACE inhibitors go, while on the one hand there's evidence from small trials that sublingual captopril and IV enalapril decrease the need for mechanical ventilation and rapidly improve symptoms, on the other hand there's no good large randomized controlled trials with ACE inhibitors in acute heart failure. And the 2007 Canadian guidelines on acute heart failure say they should not be used routinely, rather that ACE inhibitors should be used once the patient is stabilized. Moving on to morphine, the ADHERE study did show that morphine was associated with increased in-hospital mortality, ICU admits, longer hospitalization, and the patients who received morphine were also more likely to receive mechanical ventilation. But as Dr. Steinhart pointed out, this was with very, very, very high doses that we almost never use. And so, according to Dr. Steinhart, morphine still is an option in small doses. All right, let's go on to our last case here. This is a case that I saw about 5 years ago. It was a 29-year-old woman who was 1 week postpartum. She presented with a sudden onset of shortness of breath at home. She came in by ambulance in extremis. She was in severe respiratory distress with diffusely mottled skin. She appeared very drowsy and appeared to be tiring. Her vital signs were a blood pressure of 80 on 50, heart rate of 140, respiratory rate of 40 and an O2 sat of 85% on a non-rebreather. Her JVP was through the ceiling, and there were crackles throughout her chest with mild pitting edema. This was pretty much all the information I could get as they rolled in.
So this lady is an extremist. You have to assume that she's now suffering from postpartum cardiomyopathy, which is a terrible disease that can occur antenatally or up to 6 months postpartum. So it's something that you need to think about in a woman who's delivered, who's even out, who presents to the emergency department 6 months post-delivery.
I mean, we always think about PE in patients who are peripartum. I think it's important to think of all the other things that pregnant patients are at risk for: aortic dissection, cardiomyopathy,
Exactly.
Even MI.
Exactly. Well, this lady's clearly presenting in cardiogenic shock. She's hypotensive. She's got rouse up to her apices. She's kill up for cardiogenic shock. Her mortality is somewhere between 80. Short-term mortality is somewhere between 80 and 100%. So she's a very sick lady. You know. Obviously, you're going to resuscitate her. She sounds like she's going to need intubation as opposed to just BiPAP if she's that hypoxic and she's obtunded and lethargic already. So you're going to put her into resus. She's probably going to need intubation right away, and she's probably going to need at the same time pressor support.
In terms of intubation, is there anything in particular in patients with acute heart failure in terms of indications for intubation, or do you just do your usual indications for intubation?
Well, here I would be very aggressive. Akin to what Eric said about starting BiPAP really quickly in your traditional heart failure patient. In the cardiogenic shock patient, where every myocardiocyte is invaluable to sustain this patient, and the risk of retractable myocardial damage, not to mention arrhythmias. This, to me, is a no-brainer. Intubate immediately. You're not going to wait for your blood gas. You're not even going to do a blood gas immediately.
And you're going to do a lot of things for this lady at the same time. You're starting the IVs. You're preparing for intubation. You want to get a stat chest X-ray. You need to get a stat ECG. Who knows? I mean, maybe she's having something weird. Maybe she's having a STEMI, for example, right? And again, you're between a rock and a hard stone here, because on one hand she's crackling, you want to diurese her. On the other hand, maybe you should give her fluids to support her blood pressure. But I think most of us would probably, start a pressor of some sort. And again, this is the kind of patient who really needs to go to an ICU quickly, because she's going to need other types of pressors. Maybe she needs Levofed preferentially, and she needs lines in. This is, her mortality is extremely, extremely high. So you need to do what you can to resuscitate her and get your intensivist down to help you as quickly as possible, I think.
And what would be your choice of pressor?
I've been in the field for a fair bit of time, as has Eric. Thankfully, we don't see this patient, cardiogenic shock with forward and backward failure that frequently. Dobutamine is the kind of Coca-Cola of pressors. We're familiar with it. We're familiar with its actions. Its onset is fairly quick. It's fairly easy to use. There's other alternatives now. Everyone talks of milrinone, which acts in a different way, a 5' diesterase inhibitor, but it drops pressure. It drops systemic vascular resistance, which we don't have any leeway there. So I would go to dobutamine if I went to a pressor at this point. I would not drip in any ephedrine or phenylephrine or adrenaline or noradrenaline at this point. It would be dobutamine versus milrinone, and I would start with what I'm very familiar with.
Mm-hmm. Yeah, I believe the Canadian guidelines say dobutamine over milrinone. This patient was intubated and started on dopamine and dobutamine, and their pressure came up to 110. After their blood pressure improved, they were given a small dose of nitroglycerin before the intensivist arrived. The patient then went into VTAC.
So you have to be careful. So there's a patient who is completely dependent on whatever systemic vascular resistance is left. He's something to decrease preload, decrease afterload, decrease systemic vascular resistance, but so there's nothing left. So have to be very careful in these patients.
Yeah.
Yeah, so the literature, again, for a very small subset of heart failure patients, those in cardiogenic shock, the ADHERE registry says 3%, and I think even less in my experience, thank goodness. But as soon as you start a vasopressor, the mortality rate by association just rockets. But of course, why do you start a vasopressor? Because the patient is doing horribly. So you're in a bind. Mm-hmm. And you may want to go for surgical support in such a case very quickly. You know, intra-aortic balloon pump. We have other tricks up our sleeve in a major center like Toronto.
Yeah, while we were trying to set up all of the above, the patient went into VTAC. The patient was shocked. Pulse came back. And then a few minutes later, the patient went asystole and was unable to be resuscitated.
It does surprise me. These patients deteriorate very quickly.
If anything else could have been done in this particular subset, of course, they have systemic embolization because of a baggy heart if they don't die otherwise. So one should consider heparinization very, very quickly to prevent this very, very common complication if they survive the initial insult.
And there's a high mortality associated with peripartum cardiomyopathy. Some of these people, obviously a lot of these women, not everybody presents this dramatically, and a lot of people recover. But even of the women who recover, 50% of those women have persistent ventricular dysfunction, and obviously shouldn't get pregnant again. And it's one of the causes for common causes for the need for transplants these days is pericardiomyopathy. So it's a serious disease. So somebody who comes in short of breath after giving birth, previous to 4 or 5 months, consider the diagnosis and do a good physical examination, get a chest X-ray, look for peripartum cardiomyopathy.
Okay, let's move on to disposition. There are some good predictors of poor prognosis in acute heart failure. Systolic blood pressure less than 120, a low sodium, a high BUN, high creatinine, positive troponin, ECG changes, a BNP over 500, and poor response to initial therapy. And these are some of the things that can guide us, help us to decide who needs to be admitted. The problem comes when we're trying to decide who can go home. There's been about 4 different prediction rules to predict who's at risk in patients with heart failure, and their low-risk patients still have about an 8% mortality rate at 30 days. So these prediction rules aren't very helpful for us in terms of sending patients home because that's way too high of a risk. So what's your advice in terms of who should we be considering for a discharge from the emergency department?
My advice is be very, very careful before you send someone home with congestive heart failure. I certainly think that anybody with first episode heart failure needs to be admitted and worked up as to the etiology, needs an echo, needs thyroid function tests. I think patients who present with moderate to severe pulmonary edema, it's a no-brainer too. I think those patients deserve to be admitted and diuresed properly and carefully, and to have repeat cardiac markers. Silent ischemia is common in the elderly. A lot of these patients are elderly and may have silent ischemia, don't necessarily have chest pain when they present. A lot of these patients are diabetic and may not have chest pain, and you have to always worry about silent ischemia. Probably the only type of patient I would consider sending home, and I do, is the patient with known chronic congestive heart failure who is a frequent visitor to the emergency department based on poor compliance with medications, poor compliance with diet, or inappropriate use of some other medications like an NSAIDs, which may have precipitated the heart failure, and who's known to the emergency department, to the hospital, and has been diuresed in the emergency department before and presents with the exact same scenario. But having said that, it's important to remember that we do not have a good predictive model of which patients will go on to have a short-term adverse effect once you send them home. So you're still gambling. Even with that patient, you are still gambling, not knowing what their short-term outcome is going to be. Do I send them home? Do I send some patients home? Yes. Do I sleep well at night having sent them home? No.
So I'll go a step further. I agree with what Eric has said. You have to ask yourself, not in a joking way, well, if I get these patients admitted, what will their outcome be You mentioned 8% mortality at 30 days post-index visit. Well, how good are we, even if we do admit these patients, in reducing mortality? And the answer is the 1-year mortality for heart failure patients is 33%. It was that way when Eric and I started our practice 30 years ago. It was that way 5 years ago, with the multi-billion dollars of research on diagnosis and interventional medication and new medication or changing medication. And all these studies has not changed the 33% mortality figure at 1 year by 1%. This is a bad disease. These people are going to die, not always from the immediate heart failure, but also it's all-cause mortality at 1 year. Many of these patients, as we talked about, have severe diabetes and high blood pressure and COPD and atherosclerotic heart disease and valvular disease, et cetera, et cetera, et cetera. They're elderly. So they're on a thin line. And unfortunately, even admitting these patients may in the short term help, but the long-term perspective is not favorable regardless of what we do. Unfortunately, this is a bad disease.
It's not all bad news. In fact, I do think the overall care for patients with coronary artery disease has improved significantly over the past 10 to 15 years. There's no question about it. Although we see congestive heart failure, we don't see as many florid pulmonary edemas as we used to see. Hypertension is being controlled better by family doctors and cardiologists. We are taking better care of acute coronary syndromes. We have seen the proliferation of heart failure clinics in many of our bigger hospitals, and they do really good jobs of monitoring people's weights and keeping people out of the emergency department. So the news is not all that bad when it comes to heart failure patients. Unfortunately, we have to remember that the population is getting older, so we will not stop seeing patients with heart failure. But the overall, let's not be pessimistic, the overall management of patients with coronary artery disease has improved dramatically with the advent of antiplatelet drugs, antithrombotic drugs, ACE inhibitors, ARBs, et cetera, et cetera. So, we've done very well in managing acute coronary syndromes, and therefore have reduced, in many patient populations, the incidence of heart failure. Unfortunately, the patient population is getting older, so we're going to continue to see patients with heart failure.
What in the future should we be looking at in terms of research to help us improve all of this?
So what to do in the future? There are emergency physicians interested in research in this bad disease in America that now have a society going, and what they are proposing is ER-led research, not cardiology-led research. Short timelines for endpoints, not 60-day post-ER visit, not 1 year mortalities, but short 10-day, 2-week endpoints to see what effect the emergency department management has on short-term care. And alluding to what I said, we're not impacting on mortality at 1 year. Let's look at other endpoints in research. Let's look at quality of life. Can the patient maintain their activities of daily living for 2 months and forget about endpoints like recidivism and coming back to the hospital, in 2 months' time, or mortality at 6 months or 1 year. Let's just go for the more pragmatic approach.
I think what we need is a predictive model, a better predictive model, a good, validated predictive model which can tell us which patients are safe to send home or not. We currently do not have that. That's what we need, an emergency department-based trial which can give us a good predictive model.
Well, that wraps it up for this month's episode. Thank you so much to Dr. Letovsky and Dr. Steinhart for their words of wisdom. We've unfortunately run out of time for our quote of the month, but until next time, take it easy.